seconds, right? We have tubes that rotate extremely fast and allow us to do that. All of these things are done in the engineering labs and then validated in a patient environment. This fast scanning allowed us to pick up what we see here as filling defects within a structure called the pulmonary artery. This is a life-threatening complication called pulmonary thromboembolism, and again, the non-medical people may have heard of this. When you hear of people dying on airplanes, right, with long flights, you have thrombi in the veins that go up into the chest, and then the patients die suddenly. Right? That's due to pulmonary thromboembolism, and suddenly we were able to diagnose this life-threatening condition with extreme ease. Right? It's a binary problem. Is there a filling defect or not? And we're able to do this extremely well due to the changes in technology. We've then been able to scan with high resolution. This is the lung. And you can see the lung as if you've cut an actual lung in the dissection room, and then you're using a high-resolution microscope to see the structures. We're not talking of slides, but we're just looking at the actual specimen with a high-resolution microscope. And you can see these honeycomb cysts here so well, including the reticular opacities. And today, we can reliably make a diagnosis of a condition called idiopathic pulmonary fibrosis simply because of the technology that we have. We can use this for treatment planning, and I'm sure all of you have been to dentists. Some of you have had root canals. Many of you are thinking of dental implants, especially if you're 80 or 70 years old and want to look 55 or 60. And this is what we do, right? This is a cone beam CT scanner. Then you put it into special programs. The implants that are being used are then placed by the dentist on his computer before they are put inside the patient. And all of this planning therefore allows accurate planning to happen, or accurate placement to happen within the jaws of the patient without experimentation. All of this is done in advance thanks to CT scans. We've started doing 3D modeling, and in our own center we have a 3D printer that allows us to create models that would help surgeons plan complex treatments. So here is a patient. This is the craniovertebral junction. It's a very complex area. This patient has a complex CVJ anomaly, and we've made a 3D model using CT scan data. This 3D model, the surgeon holds in his hands, is able to actually do the surgery on the model, make sure that he's not hitting vital structures like this artery here, and then he would go into the patient or into the operating room and do the surgery more successfully. The other area that has impacted radiology is deep machine learning and artificial intelligence. So we work with a company where we measure the fibrosis in patients with idiopathic pulmonary fibrosis. But this was an article that came out yesterday. Now, many of you know that we measure the bone age of people. Now, this is important. For example, when you have an under-17 tournament and you think that a couple of teams have children who definitely look 18 and 19. And if you have to prove whether they are truly 18 or 17, you would do radiographs of the limbs and then try and estimate bone age. And it's a tedious process that involves matching with references, and doctors hate to do that. Artificial intelligence apparently can do this extremely well, extremely quickly, and it is as good as expert radiologists for measuring bone age. Similarly, this came out about 5 months ago, where if you were in a rural area where there weren't enough radiologists available to read chest x-rays to diagnose tuberculosis, you could use an artificial intelligence setup using deep machine learning to try and pick up TB lesions within the chest x-rays. And then if you had a question, those select radiographs could be sent to a radiologist. And therefore all of this is revolutionizing the field of radiology as we go along. But everything that I showed you today, and everything that I've showed you till now, is based upon anatomy and structure and morphology, that is static images that can be manipulated or read to give information. But you can do so much more. And over the last 3 or 4 decades, we've been able to look at function at different levels: mechanical function, physiologic function, function at the microscopic level, biochemistry related function, and histology. And I'll show you examples of those. So ever since X-rays have been used in medical practice, we've looked at some gross function. So when you do a barium study, a dye that is drunk by the patient, and then you delineate the stomach, etc., you can do this in real time. You can follow the passage of barium, you can see the motility of the small bowel, etc. Or when you're doing an X-ray of the cervical spine, you can do it in flexion and in extension. If you're doing an MRI of the TM joint, which is the joint that connects the jaw to the skull, you can do it in the closed mouth and the open mouth position. But these are very, very gross efforts at trying to understand mechanical function. What we can now do is all of this. And let's look at some examples. This is a 25-year-old patient with thalassemia. All of you know that thalassemia is a condition where a patient has a bleeding disorder which is congenital. And to prevent that from happening, the patient receives blood transfusions typically every 2 weeks to 3 weeks. Now, because the patient is getting blood transfusions, there is iron deposition in different organs of the body. So today, thalassemia patients live very long. But if they get iron in the heart, they pretty much get heart failure by the time they are 20-25 and they die. There are drugs that can be used to actually remove the iron from the heart, but you would use them only if there is iron in the heart. So you need to estimate the iron in the heart, and we do that using MR. Here is a beating image of the heart, which is essentially normal. And here is a special sequence that was developed many years ago at Imperial College that actually looks at a parameter called T2 star, which is a relaxivity parameter. If that T2 star is less than 20 milliseconds, it means that there is iron overload in the heart. And at 3.2 milliseconds, it tells us that there is severe iron overload in the heart. The same thing can be done for the liver, for the pancreas, for the spleen, and for the pituitary. And while these are important, the heart remains the most important structure that we study. Now, this is a patient in 2015 who has iron in the heart. You can see the dark structure here. But when the drug was used, you can see in 2017 that the iron has gone from the heart. So not only can we diagnose iron overload, we can also check its reversal on follow-up studies. In this patient, unfortunately, in 2015, there was no iron in the heart. By 2017, there's a lot of iron in the heart because the patient was not taking the drugs properly that he or she was supposed to do. So essentially here, MR is being used to estimate the iron content in the body. It's a form of biochemistry that we're doing, and we're looking at a specific metal in this way. And function, because we looked at the beating heart, we can look for wall motion abnormality, check if the ejection fraction or the function is normal or not, and manage accordingly. Here is another example of biochemistry. So this is a 58-year-old man with suspected gout. And this is a radiogram that is usually typical of gout. But if the serum uric acid levels are normal, and gout is an arthritis where there is uric acid deposition or urate crystal deposition within the joint, and then the joint gets destroyed. We have a technique called dual energy CT. So in that, we have two beams of different energies, let's say 80 kV and 120 kV, that go through the body. And different materials behave differently when they are exposed to two different energy beams. And one of them is monosodium urate, or the MSU crystal of gout. Now, if what we have done now is coded every MSU crystal as green. So you can see the MSU crystals as green structures here. This is a 3D image that shows it really well. And the moment we see, and we call it green as gouts, the moment you see green on a dual energy CT, because all of that has been coded, we know that we're dealing with gout because we identify MSU or monosodium urate crystals within the joints. How cool is that, right? So you can see that in the wrist joint here, and this is again a form of biochemistry. We're looking at anatomy and then we're looking at specific crystals within the body that we can identify using dual energy CT scan. We can also replace histopathology in some instances. Many of you know that when we are looking at specific tumors, when we're looking at specific structures, that histopathology is called the final word. So you take tissue out of the body, the pathologist looks at it under a microscope and then makes a diagnosis. Now, when we look at diffuse liver diseases, the common name is cirrhosis. It may occur because of alcohol consumption, which is the commonest cause, or hepatitis B virus infection, which is the second commonest cause, or many other conditions as well. One of the things that we need to do in a patient who has cirrhosis is to estimate the extent of fibrosis. Now, this is done using histopathology. You do a liver biopsy, and then the pathologist looks at the slides and says this is grade 1, grade 2, grade 3 fibrosis. The amount of fibrosis in the liver determines prognosis, determines how long the patient is going to live, etc. Using MRI and using a function called elastography, where an ultrasound beam goes into the liver, the elasticity of the liver is measured and then converted by the MRI to give us data, we can actually estimate the amount of fibrosis within the liver. So we get values of stiffness. You're actually looking at what is the stiffness of the liver. That has already been correlated on other studies with the fibrosis on histopathology. And today, based on the stiffness of the liver, we can estimate the amount of fibrosis. And today, if you have access to an elastography unit, you don't need to do a liver biopsy to estimate fibrosis in cirrhotic patients. And why is this an issue? Because a liver biopsy can have many complications, including death. So without touching the patient, you can get this information that you want. So structure and histology just using a simple MR. Let's look at another aspect of function. This is a 32-year-old with a glioma, which is a tumor in the brain. And you can see this area, the white area here, which is the tumor. Now this tumor is on the left side, and it is in an area where you have the motor cortex, which means that whatever controls the right side here is where the tumor is. The neurosurgeon and the patient want to know that when they go and operate on this, will the patient have a deficit, that is the inability to move the right hand. And so you need to know whether the area that the right hand is controlled by is involved or not. And how do you do this? One is, of course, you look at the fibers, but that's one way of doing it. But what we do is a functional MRI. So in the MRI machine, the patient is moving the finger, and we're using a special sequence to find out which is the area of the brain lighting up when the finger is being tapped. Okay, so here's the finger being tapped. That is the tumor, that is the cortex which controls finger tapping, which is essentially your entire upper limb, and you know that this is outside the tumor, and if and when the tumor is removed and if it's done well by the neurosurgeon, the patient should not have a deficit. So on the other side, that's the normal area, that's the area next to the tumor, but we can make that out, right? So this kind of information, you can also ask the patient to speak if you want to study the speech area, especially if the tumor is in the temporal or the parietal region, and so on and so forth. You can study language areas as well, and all of this can be done using a technique called functional MR. Mind you, everything that I've shown you so far is stuff that we're doing on a regular day-to-day basis. This is not science fiction. This is not from the journals. This is not stuff that is going to happen in the future. This is stuff that is happening today as we speak. So this was structure and function. Let's look at another example of function. So here is a 57-year-old lady with lymph nodes in the axilla, the armpit area, positive for cancer on a biopsy, likely suggesting a primary malignancy in the breast. However, when we did the PET-CT, the PET-CT is a very powerful tool where we inject fluorodeoxyglucose, which is a radioactive substance in the body, and anything that consumes glucose will basically light up. So that same gland in the armpit that was positive for cancer lights up. We've just coded it as orange, somebody will code it as blue or green, it doesn't matter, but it lights up as you can see here. However, nothing is lighting up in the breast. And remember, PET is an extremely powerful tool, but something is wrong. We're not getting a light in the breast. Does this patient really have breast cancer? We move to another modality. This is an MRI of the breast where we've injected a dye, and we've injected the dye and then scanned really fast, right? Multiple scans at 10 second intervals to get something called a dynamic study. When you get a dynamic study, we can do perfusion analysis. So what we've done is on the MRI breast, they found two white areas that seem to be abnormal. Then the perfusion curves were run on those, and you can see here that the perfusion curves are suggestive of possible malignancy. Now the next step will be to actually use the MRI and to biopsy these nodules under MRI guidance to confirm that these are the reason why the patient has cancer nodes or glands in the armpit. So perfusion analysis again talks about how these lesions behave when blood is going in and blood is coming out, or when the dye is going in and dye is coming out, and that gives us a basic estimate of whether these lesions are benign or whether these lesions are cancerous. So again, an example of structure and function together. Let's look at treatment. So this is a 35-year-old lady with dysmenorrhea, that is essentially painful menstruation. This is an MRI that shows a large fibroid, or women would know what fibroids are in the uterus, right? Now, on an MRI scanner, if we load a transducer that generates high intensity focused ultrasound beams, we can direct these beams into the fibroid and burn it. So a focused ultrasound beam can be heated to 60 or 70 degrees within the fibroid. We can burn the fibroid, and the MRI acts as a very expensive thermometer. So you actually know what is the temperature at the site where the heating is occurring. You can prevent additional heating, otherwise you can have complications, and you can burn the fibroid. And in this case, we burned the fibroid by about 70%. This was 1 month later, where you can see that most of it was burnt, and this is 6 months later, where 40% of the fibroid is gone and the patient has significantly improved. So we took the MRI that Paul Lautercourt and Demarian, etc. had invented. We put in an ultrasound unit that can focus an ultrasound beam, that can heat a fibroid, and we can treat a fibroid. So not only can we diagnose the fibroid on MR, we can go ahead and burn it as well. So that's structure with function, intervention, and treatment. Another example of that. So here's a 52-year-old with an X-ray that shows a spot in the lung, and this essentially looks like a cancer, but we have to prove it. So the first thing you would do is a PET-CT, and I showed you an example with those glands in the armpit. You can see that it's lighting up. Now that you know that it is consuming a lot of glucose, it's possibly cancer. What would be the next step? You have to prove it. How do you prove it? You have to get tissue out of it. Like I said, eventually it's the histopathologist who will tell us whether it's cancer. If it is it adenocarcinoma, squamous cell carcinoma, etc. And so under CT scan guidance, we can actually put a needle inside that white area. We can draw tissue out and we can send it to the pathologist. This is called CT guided biopsy, and again this allows us to get a definitive answer. Not only that, the tissue that we get can then go for genetic studies, mutation studies, anything that will help the treatment of the patient. So here we're looking at structure, we're looking at function with PET, and then we're looking at intervention. The last two cases. This is a 57-year-old who was operated for cancer of the rectum and then had these spots within the lungs. These are small spots. It's very difficult to know whether these are cancerous or whether in our country they're due to old tuberculosis. Now we could follow this up over a year, and then if they grow then you think that they are cancer, but imagine if you wait for a year and they grow, then you've lost any chance of treating these lung nodules if you could. Now, because of the advances that we have, where you can use the CT scan as a fluoroscopy machine, so in real time you can shoot X-rays and see that, we can actually target nodules that are as small as 5 millimeters, and we can put a needle inside, you can see the white needle in, and do a biopsy. So not only can we do CT guided biopsies of large lesions today, we can push the envelope and we can actually do biopsies of nodules that are as small as 5 millimeters, making a diagnosis. In this patient, unfortunately, this turned out to be metastasis or spread of cancer from that rectum. He's got about 6 nodules in the lungs. So now, whether they would remove all of them or treat the lungs with radiotherapy, that is a decision that needs to be taken. To put all of this together, right, everything that we've spoken so far, let's look at one case. This is a 64-year-old man with a suspected cancer of the prostate. So we've done everything that we've already talked about. This is an MRI where we've done a routine study that shows some abnormal area on the left side. Then we've done something called a diffusion scan that looks at the status of water molecules, and we can see something is abnormal. Then we've given the dye injection like I showed you in the breast cancer case, and we've done a perfusion analysis of that. Then we've looked at those post dye injection images, and then we've done a study called spectroscopy where we're looking at the protons and the way they behave in terms of the chemicals or the biochemicals within. So you can look at choline, you can look at various other metabolites by using the spectroscopy function of the MRI within that part of the prostate. And that again will tell us, if you get a choline peak here, then you know that this is likely to be cancer of the prostate. So when you put all of this together, the fancy term given for this is multi-parametric MRI of the prostate, but it really helps. So if my multi-parametric MRI of the prostate is normal, in a patient who is suspected to have cancer, I don't need to do a biopsy. I don't need to do anything else, because the negative predictive value of a normal multi-parametric MRI, you've done everything, perfusion, spectroscopy, etc., is upwards of 95%. If we find something abnormal, then the biopsy can be targeted to that area rather than biopsy the entire prostate. Right? So that makes a big difference and allows us to therefore reduce the number of invasive procedures as well as increase the accuracy of the MRI modality that we're using. So this was a combination. We looked at structure, function, biochemistry with choline, histology, and intervention. So while radiology has primarily been involved with evaluating anatomy, morphology, and structure, over the last couple of decades, it has slowly moved into providing functional information of varying kinds. So whether you use MR spectroscopy, elastography, dual energy CT to give us biochemical information, whether we use elastography, for example, to replace histology, whether we look at just function that is related to motion, whether we use the modality for intervention, all of this is completely changing the way radiology is being practiced and the way radiologists are perceived today in the medical community. I would go so far as to say that the only complete doctor in medicine today would be a radiologist. So any of you who are not radiologists here, you might want to think of changing your branch after you've seen all of this. So thank you so much for listening to me.
Thank you very much, Dr. Bhavi. I think you have done a very interesting talk and brought your article to a new level. And I think you have really talked about convergence. And I must thank all the scientists, people sitting here. It's their effort that which has brought radiology to this big level. And I'm sure with the deliberation that we will have, we will find a lot of new innovations, which ultimately come to the medical practice, and they will be enjoyed by all of us for the years and decades to come. Thank you very much for such a nice talk. I would like to just mention here that Dr. Bhavan is running one of the best state-of-the-art radiological centers, not only in Mumbai, but in whole of the India. And he's been often referred by the foreign countries also for his second opinion about all the difficult cases. And today, we are very fortunate that we will also be doing a MOU with this center, with our university, so that our students and faculty could also benefit with all of the benefits that is done. And again, keeping in view the time constraint, I will ask for 2 questions in case you would like to ask.
Well, it's an excellent talk. So you have witnessed all the invention in the radiology since last 3 decades. So my question is...
You're making me sound old here. Just don't say 3 decades.
It's okay. And my question is the rate of new invention is really slowed down or it is going...
No, it's all dead. There is no more innovation happening on the hardware side. There is no new paradigm shift. It's all over. So whatever we had with X-rays, with CT, MR, ultrasound, it's all gone. So there's nothing on the horizon except better ways to use these modalities. And the one challenge that will eventually change the way radiology is practiced, for good or for bad, we don't know as yet, is artificial intelligence and deep machine learning. So it has the potential to aid us a lot. It has the potential to be very disruptive. So the next paradigm shift will come not from a hardware or a software technology related to radiology, but something completely allied, and that's deep machine learning. It's going to change your field as well, except it won't take away your operating skills, but everything else.
Thank you. One more question. Sir, good morning. I have a very excellent lecture. I'm a pediatrician. So we do see cases up to 18 years these days. Second thing is these protocols which you have seen. Yesterday I was reading a book on radiology. That MIP for a structural anomaly at birth of trachea. So how do we order these tests? Because we are not very much aware in spite of being a clinician. So how do we order?
So 2 things to that. One is that yes, if you knew the terminology, then you'd say you want a minimum IP.
Yeah, yesterday I read the terminology MIP for the first time.
Correct.
Yeah.
But having said that, your radiologist should be able to do the right thing in the right situation. So if you have a hospital or a center that is reliable and you can work with well, the moment you send a pediatric a child with a tracheal abnormality, it is understood that the minimum IP and the reconstructions will be done, because that is today's state of the art, not even state of the art, it's just current practice in most places. So it's just, your familiarity obviously helps, because if you mention it, then they have to do it. But it would also be nice to just find out those radiologists in the area where you practice who understand all of this, and where you don't have to break your head the moment you send the patient, it's done.
And one more thing is, because there are different modalities are available. Like I have a bronchoscopy, I have this one, and then I have virtual bronchoscopy. So most of the time we say that the direct bronchoscopy is better and this one.
Yes,
so what is your experience?
Yeah, so as far as the trachea is concerned, virtual bronchoscopy is just a gimmick. I mean, it's of no use. Yeah, it has to be direct bronchoscopy. There's no use. The only use of any virtual scopy is virtual colonoscopy, because it can You don't need to do a direct colonoscopy when you're screening for polyps. But when you have a disease process, then you have to do direct scopies anywhere in the body. You can't replace that with a virtual scopy. So the virtual scopy, we can do it, and it's a great tool to have, but it has no relevance in the trachea.
And the vascular rings or something.
So that we would do an angiogram, we would see the vascular rings. We would do 3D reconstructions to show the trachea from outside, but you don't need a virtual endoscopy for that.
Because we don't have anything to suspect these anomalies. So can we order them?
Yeah, so patient will have stridor, right? So
yeah.
You would say that, suspected vascular anomaly, please image accordingly, or please do a CT angio or something like that.
Usually, I think, sir, you have a lot of many questions. Thank you very much. Thank you very much. Yeah. I think there are some postgraduate students from the Department of Radiology. Are they there? Do you have anything to ask him after listening? Or you will interact with him later on? Okay. Dr. Bhavin, thank you very much for such a nice talk.
Thank you, sir. I request Professor Rakesh Sharma sir to felicitate Professor Bhavin, sir. I request Dr. C.D. Lokhande sir to felicitate our chairperson, Dr. Rakesh Sharma sir. I have a special announcement. I would like to call upon stage Honorable VC, Devapatil University Kolhapur, Professor P.V. Bere sir to join the stage. So I also request Dr. Bhavi Zankaria to join the stage. As announced in the morning, we are very glad to actually share the MOU with Dr. Zankaria's clinic, Mumbai, with Dr. Zankaria sir. I would request all of you to give a big round of applause. And I thank Dr. Zankaria, Dr. Rakesh Sharma sir, Dean and Co-Convener, President Professor P.V. Bere sir, and our Convener Lokhande sir for exchanging this MOU. Thank you so much, sir. Everyone might be hungry, so we will break for lunch now. Lunch is arranged downstairs in the hall. I request you all to resume here by 2:15. Thank you.
Just give me a minute.
Without prayer, one should be given. तो दे दो ना.
Found it. Somebody put my stuff into a backpack and I just it was confused, but found it. No, it's fine. No, it's fine. And well, there's no question about this password.
So you want that password, right? You want Wi-Fi password? You want Wi-Fi password?
So perhaps if you know the
you write in it. No, that one has the password. No, that is not the password of DYP.
Let's try. I will call him.
Try digital at campus.
Just
So
try.
I'll write a password. Just try that.
If not working, then
If not working, I'll give you another one.